Hi guys, welcome back. It's Dr. Saru. Part 2 of Ectopic Pregnancy Explained. I'm going to first start off with the questions that were sent in. I only got two questions that I saw. Be sure to subscribe if not, like, share, and comment on the more topics that you want us to discuss. So the first question is, let's say a woman has been inserted with IUD loop contraceptive for 5 years. She immediately after 2 days indulged herself in unprotected intercourse for 20 days consecutively. Then she took a break, and a few days she started experiencing abnormal discharge of blood that looked like period. Could this be a sign of UTI as a result of ectopic pregnancy? One, I think your questions are a bit overlapping because you're talking about two different things. One, for UTI, there are specific symptoms that somebody feels, and you can also do a urinalysis to test this out to know if you actually have UTI. I'll put a link down below for my video or I did previously on UTI so that you can check it out. The other thing, spotting normally occurs sometimes with a person with a coil that has been inserted. And I said for an ectopic pregnancy to occur, most of the time is the hormonal coils that cause that, yes, not necessarily the copper T wire that can cause the ectopic pregnancy. However, somebody can get an ectopic pregnancy for one reason or another. I hope I have answered that question. Now, next to the second question. Somebody was requesting I put up the sites and the percentages of the occurrences. The next slide, you'll find out that I've put a very elaborate, slide that has the percentages and the sites of occurrence. Please be sure to either stop the video there so that you can check it out. If you're using your phone, you can take a screenshot so that you can have it with you. I hope I've answered. Now let's go back to the main topic. There are three main treatment options: expectant management, medical management, and surgical management. Today, I would like to mainly speak about the medical management. However, I'll do a brief on the surgical management. So on the surgical management, what we can do is there is the laparoscopic procedure or method, which can be both therapeutic and diagnostic. You can go in laparoscopically just to check where the ectopic pregnancy is, and as well as remove it while you're in there. It's the method that is mainly recommended, especially in facilities where they can do the procedure, because it's less invasive as opposed to the open method. The other surgical procedures, of course, you can either do milking, which some thoughts, I've read some books which are not quite they don't quite recommend that method. But if the ectopic pregnancy is, let's say, at the femoral end, you can just milk it out without much of any harm done to the tube. The other one, it's either you can so in surgical, you can either do salpingectomy or salpingostomy, depending on your fertility option of your patient and whatever you and your patient discuss. For a patient who desires to maybe bear more children and there's no rupture, then you can do a salpingostomy first. That is just you cut through the tube, you remove the product of conception, you try and suture the tube up so that she can have future children if she would want. And it's not necessarily that she might be able to. I mean, you'll discuss with her all the surgical what are they? The surgical complications that can occur. And for salpingectomy, then you just cut where it's basically like removal of the tube, yeah. So I bet you guys understand that already. So you'll just cut off and you'll suture or tie or like get the tube and remove that part of the tube that was affected with that ectopic pregnancy. So let's dive into the medical management. The patient should be hemodynamically stable, because if a patient you're suspecting a rupture showing signs of shock, then that is a patient that you should not try and do medical management. 2, no severe persistent abdominal pain, because that is another indication of a rupture. 3, the ability to follow up multiple times, because you'll be needing to, this patient needs to be on follow-up just in case the medical management fails or there's a rupture that happens, or even for the, if you're doing multiple dose regimen, to be able to administer the medication, and also for checking the levels, the beta hCG levels. And 4, normal baseline liver and renal function test, because you need a patient who also the liver test and the renal test are on point, like they're good. I'll explain shortly why you need the baseline for liver and renal functions to be good. So we have single dose regimen and multiple dose regimen, but the single dose is what has become most popular, only because of compliance issues and also less adverse effects. So as mentioned before, it's the popular regimen. It involves the dosage is 50 milligrams per meter square. You can give it as a single injection, or you can give it as a divided dose to each buttock. The multiple dose multiple dose regimen, it involves administration of methotrexate as 1 milligram per kilo IM on day 0. That's the first time you get the contact with the patient. Day 2, day 4, and day 6. And it's normally followed by doses of leucovorin at 0.1 milligram per kilo on day 1, 2, and 3. This helps day 1, 2, 3, and 5. This helps with minimizing the adverse effects of methotrexate. As we know, it's a chemotherapeutic agent. I think now we know how we can administer the drug, and we are aware of how the multiple dose regimen and the single dose regimen. Now let's look at the contraindication, the absolute contraindication to the drug and the relative contraindication to the drug. I'll specify which ones are, but I'll just run through all of them, yeah? So undocumented hypersensitivity to methotrexate, that is an absolute contraindication to the drug. If you have a pre-existing intrauterine pregnancy, that is also another absolute contraindication. Breastfeeding, 3, 4, immunodeficiency, alcoholism. If you have alcoholic liver disease, leukopenia, anemia, or active pulmonary disease, then it's also contraindicated. The side effects of the drug, that is methotrexate, include abdominal pain, dizziness, diarrhea, nausea, and vomiting. So if a patient experiences this, you're supposed to just encourage them, or rather give them the support needed so that they know that these are the adverse effects that we're expecting from the drug. But however, if a patient continues on with excruciating abdominal pain, then you should be worried that maybe your plan or the medical management is failing, could be a sign of rupture. So you need also to be aware of that. So how would you know then if your medical management has failed? That will be the last slide for today. I'm so pumped. I'm so happy that we've been able to do this, and that we're almost concluding this topic. So if the beta hCG levels have not dropped by at least 15% from day 4 of administration of the second dose, or if it was just a single dose that you're giving, you can repeat the administration of the drug. If, however, you realize there's no drop that has occurred by day 14, surgical therapy is then indicated. I'm so glad that we were able to discuss this. If there are more questions, please be sure to comment, or you can tag me anywhere from the post that I'll be doing this coming week throughout my Facebook and my Instagram. Please be sure to like, follow, comment, subscribe, and share. Until next time, it's Dr. Saru. Love and love.